Okay, good morning. We're continuing our sessions here in the Endovascular Theater, and we're now going to a live case demonstration session on AAA endovascular therapies from Asan Medical Center. I'm Bob Bersin, your moderator, and I'm also joined by Dr. Kishore Sieunarine. Welcome. And we have a distinguished panel, and I understand we're going now to Asan Medical Center live. Good morning. Can you hear us?
Yeah. Good morning.
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 Yeah. I'm Dr. Lee from Asan Medical Center.
Good. And then also Bob Bersin here, your moderator here, and also Kishore Sieunarine is also with me, co-moderating. We have a distinguished panel of more than a half a dozen physicians from around the world. So with that, why don't you go ahead and introduce us to your case? I understand it's an endovascular aneurysm repair.
First of all, I introduce our team. The right side is my brother, Dr. Lee, another Dr. Lee from the Cheong National University. And the second is the surgeon, vascular surgeon from the another university.
Okay.
So this is I think that we introduce our case.
Yes, this is a 79-year-old man with asymptomatic AAA. PowerPoint 보죠. And the size of the maximum size of abdominal aortic aneurysm is 62 millimeters, infrarenal type, but is extended to both common iliac arteries. Next slide. He has a risk factor for diabetes, smoking. Next. And coronary angio was not taken, but the coronary CT angiogram shows normal coronary artery, so we skipped the coronary angiogram today. Next one, CT. Would you show the CT on the screen? Yes, this is a infrarenal type AAA. The proximal leg is very, very long and very tubular shaped, not conical, so proximal landing doesn't matter. The proximal neck length is around 5 or 6 centimeters on the CT screen, CT angiogram, and iliac aneurysm is both common iliac arteries are seen. The left side common iliac artery size is around 18 millimeters. Right side is 26 millimeters. From the bifurcation to the internal iliac artery, the length is more than 3 centimeters.
Yes, okay, so
is there any comment or suggestion?
So if I understand you correctly, you have ectasia of the common iliac arteries, but dimensions are within the realm of that treatable with endografts. So we have only the 3D MIPS reconstruction here. On the axial images, is there a significant amount of surrounding thrombus or not in the iliacs?
CT angiogram axial image 좀 보여주세요. 두 번째 페이지. CT. 두 번째, 그래. 쭉 내리세요.
Great. Yeah, we'll just run through the axial images of the abdomen.
더 내려줘요.
더.
계속 내려가요. 계속. There is some sacral aneurysm on the thoracic aortic arch, but it's close to the left subclavian artery. If we want to treat the region, we need a hybrid procedure. So we want to treat the aortic aneurysm today. Next.
Yeah, good. Let's see the iliacs here.
Okay.
Yeah.
So you have an elongated, somewhat angulated aortic neck, but it's certainly one that's doable. And very large AAA.
Partial thrombus.
No doubt about that.
This is both common iliac aneurysm. Left side is 18. Right side is partially filled with thrombus. Next, 좀 더 내려주세요. The maximum diameter is 26. Aneurysm of right side extended to the ostium of internal iliac artery.
How large is the right side? The right common?
Right side is 26.
26.
26. So, Kishore, what do you think of this right common iliac?
I don't think the current generation of grafts, even with the flared ends, will fit comfortably in the 26. The configuration of the bifurcation is conducive to an IBD. And if this was a case that I was doing, I would consider putting an IBD on the right side and the limb on the left side.
Okay, other panelists, would you embolize the internal and extend or use a pre-manufactured hybrid bifurcated internal iliac device, such as a Gore device, if that's available? Comments from the other panelists? Feel free to speak
I'm
up.
a vascular surgeon. This right common iliac artery aneurysm is around 26. It's less risk for the rupture. So if this patient has a little problem in a pelvic circulation, we can save this right side internal iliac artery with the bell button technique from the Medtronic device. So that is another option.
Okay, so basic strategy, preserve the internal iliac or occlude the internal iliac. Show of hands from the panel. Who would intentionally occlude and go beyond the internal iliac to the external? 1, 2, 3, a fair number. Who would try to preserve flow to the internal iliac on the right side? Okay, a few. It's pretty much mixed. Okay, so you have a mixed panel about whether to try to preserve or
what is your
occlude the
opinion?
internal. So it's about
What
half
is
and
your
half
opinion?
here. About half and half.
Yes, because this patient is a little bit old age, around 80 years old, so maybe preserving internal iliac artery is a good option. If he is very young, we have to maybe cross over. But we chose internal iliac artery embolization technique today.
Yeah.
So,
We already inserted the.
잠깐만. Okay. 잠깐 기다려봐요.
Okay.
So, this is an angiogram we accessed from the contralateral femoral artery.
And then we inserted the thermal wire into the internal
Thermal wire.
thermal wire inserted and followed the right jumping catheter. And we changed with the ample steel wire. And we insert the 6 French insert cyst for the delivery of the plug. And then we insert 14 plug device. Because of the vessel size is around 9, 10, so we wanted to make the compact sealing like this.
So this is a Amplatz vascular plug.
Yeah,
Yes,
yeah, yeah.
14 millimeters Amplatzer vascular plug.
Okay.
It's located on the proximal internal iliac artery.
So we check the angiography after the implantation. Some flow, however, I hope that maybe syrup. Okay, this is the baseline angiography of the AAA. And you can see the very large aneurysmal change, however, enough landing zone from the left renal artery. So we don't care about the proximal landing. So we wanted to make the precise location of a device to the left internal iliac artery. Our focus on the left iliac artery main body location because of the proximal landing zone is very, very nice and very long.
From the left renal artery to the left internal iliac artery, the length is around 17 centimeters by the pigtail angiogram. So we have chosen 166 millimeter length Medtronic device. And the proximal diameter is 28 because the proximal leg the diameter is around 23, so we chose 28. For the distal left common iliac artery diameter is around 18, so we chose 20 millimeter for the distal landing zone.
So we already marked the left internal artery on the screen. So to see where is the device. So now insert main body from the left side.
So as he's working here, it'll be very important to be cognizant of the distal common iliac bifurcation on the left and not to intentionally occlude the internal iliac since he's embolized the right. I think it's reasonable in this case to go the route of embolization and extending the endograft beyond the internal on the right, given the patient's age and the fact that the internal iliac on the left side is normal. Most of these patients will have intermittent claudication for a brief period of time, but over a few months will have the return of pretty normal activity, especially in this age group.
Dr. Bersin, I have a question for the operators. Yeah, since we put in the Vesca plug in the right side, I usually practice put in the main body from the embolization side rather than the opposite side. I don't know why they put in the opposite side. Can you explain?
Yeah, it's a good point. So question from the panel is, since it's so important to be precise about your placement on the left side, not to occlude the internal iliac, the question is whether to do the main body from the right side rather than left side.
Okay.
So,
I agree with Dr. Jang. Right side is main body is suitable, I think. Another problem is left mid common iliac artery was small diameter and circumferential calcification. We can see the transverse CT image.
I don't think it
so the
matter
point
much.
being, you know you need to extend on the right side anyway to the external iliac. You could put the main body up there and then pick your extension to go into the external. And then on the left side, you have more freedom to pick an iliac extension limb to be certain that you don't cover the internal.
Now we partially deploy the main body, and we want to re-engage the contralateral limb from the right side.
So it looks like you have a cross-limb configuration here. Was that intentional or just by chance happened to flop that direction?
Manufacturer recommended me the around 12 direction. This is actually
So I'm sorry, was that
usually
intended
we,
or
intended. Yeah.
intended, intentional?
Yes,
This
intentional.
limb position is a kind of a ballerina position. But
Yeah.
how do you think
It's
about
easier to re-engage
ballerina
it.
stent graft?
This position is easier to re-engage.
So rather than have the contralateral limb on the ipsilateral side, it's on the contralateral side. So the limbs will be crossed, so-called ballerina or cross-limb configuration. It adds length to the limbs. It can be advantageous when you're dealing with extreme iliac tortuosity below. But in this case, you don't really have that much.
JR 하나 찾아줘요.
저희랑 누구? 좀 해주세요.
This patient has calcification at the proximal part of the external iliac artery on the right side, and I wonder whether the iliac artery size is a little bit smaller than, so 6 or 7 millimeters. That's why they took the left side for the main body insertion.
It looks like you're using a pigtail catheter to try to cannulate the contralateral gate. Is that your catheter of choice? A lot of times people use a comfy catheter or just a Cobra diagnostic or vertebral or something just with a moderate 45-degree angle.
Okay.
In this case, it looks like a
So I
Se-Whan
just
Cobra
tried
would
to-
work well. Comfy catheter. It looks like the pigtail here is hard to control.
Okay.
Dr. Lee,
JR.
제가 주세요.
Dr. Seung-Whan Lee, how about to use Joaquin light over internal mammary
we are
catheter?
Yeah. We change.
We are changing now.
Okay. However, usually I enjoy the pigtail. Pigtail is nearly 90% is successful.
Really?
And then as you're doing this, especially if you have a cross-limb configuration, you have to be careful about your torque and rotation of the diagnostic catheter because then you can wrap it around the contralateral limb more than once, in which case then deployment of the endo leg is difficult. So you want to make sure you don't have wire wrapping around the contralateral delivery system.
Okay.
So far he doesn't. It looks okay. There you go. It's a better angled catheter.
너무 가까워. 응? 너무 가까워. 맞았어.
So what is the size of the main body?
So 28.
28.
28, I think.
20, 20,
And the distal iliac
Yeah.
size?
Distal 20.
20.
20. Because this distal iliac is 18, we chose 20.
May help to pull the diagnostic catheter back a little bit.
Uh-huh.
Okay.
Thank you.
There you go.
아하.
Why don't you use some other projection?
Okay. I'm doing.
Good.
It's not in. It's okay. You might need to sweep the diagnostic around.
Yeah, you should feel very comfortable. We've all been in this situation, and all the maneuvers that you're doing, we've all done that in our careers.
Just a moment. Just a moment. Okay.
Yes, we'll do so.
Okay. No.
No, no, no.
Okay, well, while you're cannulating the contralateral gate, there's another case underway in the next room. Let's switch over to the other room, and then we'll
Yeah,
come
yeah,
back
yeah.
to you after you've cannulated.
Okay.
Okay. 됐다 다시.
Good morning. Hi, Bill. Bob Bersin here.
Bob, how are you?
Great.
Good to see you. I'm joined by Dr. Kyoung and Dr. Choi here. We're three cardiologists, which is dangerous, you know. You should have a vascular surgeon somewhere in the room, but anyway, here we are. We have a good case for you, and actually we got the easier of the two cases. The other case they're doing a terrific job with, and it's going to be a great outcome. We have a more straightforward case, a 76-year-old gentleman with a symptomatic AAA, asymptomatic AAA found on CT scan for abdominal pain, actually symptomatic. He has a 5.6 centimeter AAA. It's infrarenal. He had a prior history of a stroke and PCI about 9 years ago, in which he's done well with. He has a history of hypertension as his only other medical history. If we can go to the CT scan, we can show you the anatomy quickly. So here's the reconstruction image, and you can see that the access vessels are quite favorable. There's some disease in those common iliacs I'll show you in a minute. There's a little bit of a jog here, but for the most part, it's a straight up and down procedure. No accessory renals. There's a inverse taper here, which we'll show you on the CT scan and angiography in a minute. But that's the gist of it. If we can go to the axial images, we're going to roll through these quickly. Okay, slow down. Okay, there's the right renal, left renal is lowest. You see it gets bigger here. Just stop there. When we, just before the aneurysm begins, the measurement of the diameter is about 22 millimeters. At the renals, it's 18 millimeters. And so we've chosen a 25 millimeter device, which should take care of all of that reverse taper and also allow us to have lots of coverage of what is a pretty lengthy neck, actually.
That sounds reasonable,
Okay, let's
Bill.
keep going on the CT scan.
What did you estimate the length of the infrarenal neck to be?
Boy, I'll tell you, I'll show it to you on the angiogram in a minute here, Bob. Hold on one second. Go back on the CT scan. Okay, you can see right here there's some disease, like a small contained dissection or maybe a ulcerated plaque in that right common iliac. You see that, Bob?
Yes, we do. We see it very well.
Yeah. So our intent is to cover to the hypogastrics and eliminate all this disease. Okay, let's go now to the angiography and see if you can see that. There you go. Let's get ready to stop this. Can we stop this there? There you go. Beautiful. Okay, so Bob, you can see the marker catheter. It's at least a 3 centimeter neck.
Yes, we
especially
see
given the size of the device that we have chosen. We've chosen to go into the right side. The right common iliac is relatively longer than the left common iliac, and we'll be able to measure our limb extension on the left to be more exact for that placement.
that. Right. Is the internal iliac diseased on the left? It looks like the plaque in the distal common iliac extends into the bifurcation.
I think you're correct.
The patient history described
Not too
that
bad, though.
the patient
Not
had
too bad.
abdominal pain, and the pain was related to the aneurysm.
I don't think so.
He doesn't think so.
Okay, so comments from the panel. Fairly
Okay.
straightforward anatomy here. It just has a gradually reverse tapering neck, but the neck length is adequate. You have atherosclerosis in the common iliacs, but this is what we call level 1 kind of configuration, no particular issues. Infrarenal graft, suprarenal fixation graft, does it matter? Device choice, does it matter at all? Comments from the panel?
I think that this aortic neck is like a conical shape, and proximal 1.5 centimeter will be a good landing zone for this case. So actually, when we decide to put in the device, we need to focus on the very proximal leg, and the suprarenal fixation device will be better for the precise deployment.
Yes, so I would say so too. I mean, it's not the best neck, right? It's a little short. Reverse taper, I'd probably choose a suprarenal fixation device rather than infrarenal. Comments from the others?
I would agree absolutely with all those factors present in the neck. The suprarenal device would be more
Have a
appropriate.
small test.
Small test.
Okay.
Okay, back to you, Bill. Tell us what device you have here.
So we have a Medtronic device here, and you can see, I'm just going to take a picture here real quickly. Ready?
Yeah.
Yeah. Didn't feel the left there. Hold on. Let's try that again. Okay, here we go. So this is probably a reasonable place. I think, Bob, you can see the markers there for the fabric right at the pigtail.
Right?
Okay. Now I'm going to do live fluoro, and you can see at the bottom, I've got the contralateral limb markers on the left side.
Yes.
So as opposed to the other case which flipped them, we're going to keep them fairly standard.
Good. I would agree with that.
Okay? So the first thing to do is we're going to start to deploy this, and then we'll do our final positioning after we get a couple of wire forms out.
It looked like the left renal was just slightly lower than the right.
Yeah, we think that's correct.
So may I ask again what size device in terms of diameter?
It's
do
at
you
25. I think.
25.
25. Let's go magnified ones.
So with the reverse conical shape, do the panels tends to oversize the size of the stent graft a little bit, especially with angulation?
Test.
Yeah, he's sizing it more to the lower end of it on the reverse taper. There you go.
Okay.
So,
I'm
Bill,
pretty much liking that right there. Test again.
Test here.
Yeah. Push this up.
Yeah, we presume you have like
Take a
an
picture here.
overlay roadmap or the screen's being marked for you.
It's not, but we could use that.
Might still be just slightly high with the fabric.
It's a little high. Yep.
That's okay. You can start a little high and pull back.
I like that right
Is
there.
there any posterior angulation of aorta neck on CT scan?
No, not really. It's pretty straight. Are you ready?
Ready.
Yeah,
It's not filling. The pigtail's a little too low.
Yeah.
The other thing I use is a straight angiographic flush of 5 French so it doesn't get entangled and it fills laterally rather than inferiorly. You can see you're plenty low, maybe
So I'm
even
gonna have to
too
scroll.
low.
Yeah, this.
No, I think that may be right, actually, Bob. I'm just going to spin this pigtail and see if I can get a different filling pattern.
Yeah, you may want to go up a little bit.
There you go. Okay, let's try that. Here we go. Yep, I like that.
Yeah, it's a good placement.
Okay, so we're going to complete this deployment back at least to the contralateral limb.
Mm-hmm.
Then before I deploy the barbed suprarenal fixation, I'm going to pull down that pigtail.
What kind of guide wire do you have in there? Is it a stiff wire, a Lundquist, or what do you have?
It's a Lundquist, yeah.
Yeah, it's good. You can see it's not moving at all. There was no inferior propulsion as he deployed. It's really staying quite stable. And once you have the contralim out, you have no flow
There we go.
restriction. So
hold
it
on
should
a
be
second.
quite stable there.
Okay, go ahead.
Do you ever deploy the top cap before you cannulate the contralateral limb?
There he goes. He just did.
I just did. So, thank you for that question. We'll go ahead and take this. Yep. So if you want to, Bob, and you want to go back to the other side,
Perfect. We can do
I
that.
just thought we'd give them some relief, and then we come back and show you our gate cannulation and deployment.
Very well. We'll come back to you. Let's go back to the other room.
Great. Okay.
Okay.
Hi, Dr. Lee, Dr. Bersin here. We're back.
Yeah, welcome. Come back.
X-ray 5번.
Now we explain what you have.
So fill us in on what you've done.
Yeah, jogging catheter does not work, the engagement of the contralateral limb. So we changed the Banshee, maybe Banshee, I don't know exactly.
The Banshee catheter?
Banshee
Sure.
catheter is, yeah.
Uh-huh.
Banshee is maybe help the guide us, our guide wire, easily going up.
You know, often when you do an intentional cross configured or ballerina style graft, the angle to cannulate the contralateral grate becomes more significant, and so cannulation can be harder.
So we changed with the wire. We tested the location of the wire, the freely movement, the tip
Good.
catheter may
Catheter spin to make
And
sure
then-
you're within the limb and not trapped
Yeah.
behind.
And then we check the status of the internal iliac on the right side. You can see the plug. So plug guides us the location of the internal iliac. So we choose because of the enough length remained. So we insert the first 12.
So tell us
device.
what size limb is that?
This is proximal is 16 millimeters.
Yes.
Distal landing is 10 millimeters. The length is 120.
And I'm
This is
sorry.
a little short, so we need another limb extension.
Uh-huh. So it's a tapered limb.
Yeah.
Yep.
Okay. I'm going to move.
Then you'll put one more extension into the external.
잡아요, 잡아줘요.
So we wanted to remove device.
So while he's doing that, I'll just make a comment about embolization of the internals. Ideally, you want to have your occluder plug proximal to any
Another device
branches,
has it.
and a lot of times you'll see some small branches like this one had that can be a pesky source of retrograde endoleak later if you don't cover them. So this implant's occluder plug is fairly distal, and I think there's a branch or two proximal to it. I would put it more proximal right at the origin to make sure you're occluding any potential retrograde source for collateral endoleak, because if it happens, it's really hard to get to, really hard to manage.
Okay. So now we use another
This is
contralateral limb.
18 millimeter length extension. The diameter is same for the proximal distal 10 millimeter.
So 10 by 80. Sounds like.
10 by 10.
Yeah, yeah.
80 millimeters
Okay.
length.
Okay.
So yeah, 10 millimeter diameter for the external and then 80 millimeters long.
Okay.
Okay.
Just
Okay.
plenty long.
There.
Three.
Okay.
Okay. Implant. Slowly.
Notice he's getting a good amount of limb overlap, junction overlap.
Doctor, the sheath
at least
position
2,
is
3 cm.
high. Sheath literally.
Oh, yeah.
Sheath
Yeah, yeah, yeah.
position is right high.
Okay, thank you. Thank you so much.
Okay.
발 잡아주세요.
아 잡고 드리블.
So now with the dedicated branch
Okay.
limb internal iliac devices, it's possible to do these
Okay.
cases and
Jang?
preserve the internal iliac, which is it's a nice addition.
오케이, 라이언 주세요.
There's a couple of different designs that
이쪽
are out
빼고는
there that
이쪽
are through various stages of the approval process, including Gord, Medtronic, and even Endologics.
뺄게.
오케이.
Okay.
아니 왜 밑에? 아니 밑에 다 피세요.
So I wanted to relieve the main branch.
I take it you've marked your screen for the origin of the internal to make sure you don't cover that on the left.
네.
약간 민다.
안 밀지 마. 충분해.
Okay.
오케이. Say floor.
Just a moment. The
That's a 20
Phone
millimeter on the
capture?
left, I
Okay.
think.
phone capture. Phone capture. Okay.
The system 좀 밀어주려고.
So now he's recapturing the
Okay.
so-called pin cap or capsule.
Okay. Store. Okay.
쓰면 되겠죠?
Okay. So remove the device. Slowly. Some problem.
It's okay. Go ahead and yes, go back and forth. And you may
Rotate,
need to
rotate.
pull the stiff wire back to the floppy segment.
오케이.
Okay.
Okay.
Oh no.
No.
나왔었는데. 천천히.
So this is happening because of the neck angulation here.
오케이.
Okay. Yeah. Some
So he's
rotation
he
make
did
the
some
facility.
twisting, and the other thing you can do is replace the stiff wire with a soft wire.
When in that situation, a proximal cap attached in the bare metal area, I simply
wire 조심하고 wire.
withdraw the stiff wire and stent graft are movable inside of aorta.
Zoom out.
나간다. 시스 줘요. 920 시스 아까
Okay.
썼던 거.
Store.
시스 주세요.
프렌치 릴라이트 안 들어가요.
아니 일단 껴놓기 피나니까.
So now you're going to balloon all the junctions, or just take an image without?
Yeah.
Yeah.
Reliant balloon is ready for the dilatation. 넣어놓고.
To stop bleeding, we insert the 9-branch cyst already used in the
빼지.
femoral artery access. Okay. So we now insert the reliant balloon from the control artery ring. Okay, go.
천천히. 조심.
Okay. Okay.
So tell us what balloon you have here.
This is a Reliant.
Reliant.
And
Reliant
I will
balloon.
make,
Okay, so it's compliant
linear projection to make a
post-dilation balloon,
perpendicular line.
silastic balloon.
뭘 했는지 모르겠다.
Okay, 저장. Okay, bleed.
약간 밑에서 한 번만.
Okay.
I think in this case it's
Okay.
important to balloon the neck there to get confirmation because it's it's a fairly angulated neck there.
Okay.
Eliminate any chance of type 1 endoleak.
영상 부위.
Okay. 내려온다.
잠깐만.
And then most of us would balloon all the overlap junctions, especially at the manufactured bifurcation. Make sure you don't have a type 3 junction leak.
나온다.
잠깐만.
Dr. Lee, did you check the left internal iliac artery before deploy the main device?
Yeah.
We didn't
No,
see
no,
the
no,
internal
because,
iliac artery for this case.
잠깐 했잖아.
Yeah, we presume
Yeah,
you had it marked on the screen or overlap.
Yes, we
Roadmap.
already. Okay.
Okay.
It'd be nice to see a retrograde injection in the sheath, huh? To make sure it's open.
Okay.
During the device inside the body, I cannot check
교정,
that.
잠깐만.
So he's
교정.
doing brief inflations just to take out any fabric folds or kinking. There's not really any stenosis in this anatomy of any
Okay.
significance.
나오고
Okay. Okay.
거기. Okay.
Okay.
There, where he transitions to the external, it's just a smaller diameter.
Okay.
교정.
자, 시스 줘요. 다시.
Okay.
라인
아,
시스.
a little bit more lower. One more time. Okay. Okay. More. Go. That's cool. Okay.
Okay.
Is the patient under general anesthesia?
Yeah, because of today's live demonstration, so I don't want to.
How many of you do the procedure under general anesthesia?
Yeah, okay,
Nothing.
so pull the panel. How many do
Only for
most of their
today.
cases, majority of their cases under local with conscious sedation versus general anesthesia? The votes for local is in the majority.
한다. 라인 도세요.
And then general? Who does general for all cases? Not many. So the majority of the panel
안 해도 돼. 하지
typically
마세요.
does their percutaneous access cases under local with conscious
Yeah.
sedation.
Yeah. Maybe save to patient.
I have one question
Our case
for
also.
all panelists.
거기를 한번 가자.
Do you know long-term data of ballerina position? Ballerina position and across the here. The SOSM is very nice. Selection is very easy. But this position is long-term data. There is no long-term data. I think sometimes it is opera values.
Yeah, not a lot of long-term data on comparing the two. The main thing that you can run into is limb kinking, and also the columnar strength is reduced when you have cross-limb configurations. But if you're using a suprarenal graft with good hook fixation, the migration issue isn't so much an issue anymore. But it's more the limb patency can be more of an issue. So I personally don't do intentional cross-limb configurations unless the anatomy dictates that as far as extreme iliac tortuosity.
If patient have a small distal aorta diameter, is a ballerina position is sometimes a problem.
Yeah, I think with a small distal aorta, whether they're traditional configuration or cross-limb can really be a problem, and you really have to crack the bifurcation, and having a cross-limb configuration may just make that even accentuate the problem in a small distal aorta. So typically in a small distal aorta, I stay with a straight configuration, and you have to post-dilate both limbs with two balloons.
마치카 선생님, 잠깐 숨 좀 참게 해주세요.
So now we check
Bersin, I think that the standard coverage to the left common iliac artery may not enough for this case. So we need to check the internal iliac artery before finish the case.
Yeah, I think we need a good cine angiogram, retrograde angiogram of the iliac there on the left. Make sure you have a good seal, and you're down to the distal common iliac.
Yeah, usually at least 2 centimeters is needed for the secure distal sealing for the iliac arteries.
Yeah, this one looks like it's close, huh? Not that much. 2 to, might be only 2. We'll see.
잠깐 밀고요.
15에 30으로 올려요.
And you see, because of the neck angulation and the cross-limb configuration, he's lost some length. You know, he chose his length to go right down to the distal bifurcation, but I think he lost some length in the process.
벤트,
선생님, 펜트 오프 부탁합니다.
마치카 선생님, 벤트 좀 오프해 주세요.
예, 간다 샷.
네. Okay, there's gap between the left common iliac.
It's probably adequate. I'm not sure an extension would do much. Debatable whether to extend that or not.
So during angiography, we suck the blood in the both cysts, so make the good imaging.
Do you think we need extension for the left iliac artery?
Yeah, I mean, that's an operator discussion item here. I think you have a good seal. It is relatively short as far as the length of the landing zone and your coverage. You could extend it. It looks like the extension would only go about another centimeter. So I think it's operator discretion whether to extend that or not. What does the panel think? Leave it or extend it?
I think that this is enough for this case. But when you put the device from the right side, we can easily control the contralateral deployment for this case. I'm wondering why you did deploy the main body from the right side, left side rather than right side. We have a, for this case, we happen to put in the additional 2 more limbs for this case, and hard to control the left common iliac landing zones. Do you guys any reason for deploy the main body through the left side here?
So points well taken. Still bringing up the issue of main body deployment from the left versus right. The panelist was suggesting it would be better to have done this from the right side, and then you could more precisely land your iliac extension on the left all the way down to the bifurcation without covering it. That being said, you have good coverage and the outcome's good here, but I think as far as discussion of technique, perhaps tell us what your thought process was. Primary bifurcate deployment left versus right.
In this case, the left common iliac artery is long enough, so I think in such a case, I think it doesn't matter that much. But with short common iliac artery, maybe each millimeter will be critical. So in that case, I would do as Dr. Jang Kim suggested. So I will choose with the right side. But in this case, I think either way is okay.
Yeah, I agree.
I think we see where they're coming from. The bifurcate was intended to be the proper length and proper diameter just with a single piece without having to use extra extensions. So the outcome's good, though. It looks nice, I think.
Dr. Lee, how about check the left common iliac angiography through the left femoral artery and sheath withdrawal? Because to check the calcified middle external iliac artery region and then check the Taiwan and the left common iliac artery angiography will be better.
이거 라이언스 나갈게요. 네. 컴퓨터스는 10에 15 정도만 줍시다. 10번.
About 20 cc is better.
20 줘요. 야야야. 하라는 대로 합시다. 10에 20.
So I think we'll take a final image here, then go back to the other room to see how they're finishing up.
Okay. Okay.
So we'll just have a look here at their final injections, and then we'll switch back over.
됐어. 그것만 가져. 나갈게.
So just a technical note, when you're doing your final imaging on the side and you have intentional occlusion of the internal iliac, it's usually helpful to suction the blood out of the sheath as you're injecting to promote flow into the limb that's going into the external iliac. Because often the sheath will occlude outflow in the external iliac common femoral, and you won't fill it that well otherwise. So active suction on the right sheath when you're doing your final angiogram can help image it better.
Okay. 찍습니다. 쏘세요.
So this is a key step to make sure you have no retrograde leak.
당겨. 오케이, 좋아요.
Yeah, there is a little bit getting around.
Some leakage?
Have you ballooned that side yet?
No.
I think I would take the Reliant balloon and smooth it out. You have just a slight retrograde type 1 leak, distal attachment side leak. Very subtle.
Very subtle. Do you need an additional balloon for the distal?
Yeah, on the medial side, you can see it tracking up just a little bit. I would just balloon it with the Reliant balloon. I think that should take care of it.
Okay.
딱이죠.
And then while you're doing that, why don't we go over to the other operating room and see how they're doing?
Thank you.
Okay.
And we can come back to you for your final. Hi, Bill. We're back.
I got it. Hi, Bob. I got you. So we're just going to go and show you our cannulation. So this is JR4, which is what they have here. And we got lucky and got it in there.
look
And then we're going to go
straightforward.
to the next image. Yeah. Spin the pigtail.
Always helpful.
And then we took a picture here with a marker catheter, and we measured as soon as I stop fumbling here,
About
we've
6 to the
measured
bottom.
6.
Yes.
Yep. And then we have a 93, so that'll be a perfect overlap.
Yep. Sounds good.
We have inserted now the appropriate sheath here, and we're going to go ahead and put that device in. Okay. We have a 20/20 caudal contralateral view that really opens up that bifurcation really well and allows us to see it without any equivocation. I don't know if you use that in your lab or not.
Oh, sure, yeah. The contralateral and then adding caudal is often helpful. Not always needed on the AAAs, but in this case, it looks like it's very helpful.
So we like that right there, huh? Yeah? We okay? All right. All right. You know, I always...
I
I'm a guest,
presume
so I like
someone's
to be
marked your
polite.
screen. It doesn't look like you have an overlay.
Yes, we have a good screen mark here. Thank you. And this is a nice device because I can do that with it. Okay, a little bit.
So if anything, you might be just a trace high. That's fine, though. Looks like you have
Sure,
adequate
yeah,
coverage.
It's not too bad. Yeah, I think we do. So I'm going to pull this back in. Okay, we'll take that out now. Okay. Great. Let's just leave that in there like that so it doesn't leak. Good. Okay. So now we're going to come back to the AP. We've already deployed the contralateral limb. You can see that. We've detached it a bit.
Yep.
Get rid
I
of that
see it.
shadow. I pushed the top cap up a bit, and now I'm going to recover it.
This one first.
Yeah.
So reconstraining the top cap so it doesn't catch so much on the way out.
Okay. And we go ahead and pull that out. And then we'll put a pigtail catheter on this wire.
Are you going to balloon the junctions or just to do an angiogram?
We're going to do we're going to balloon everything, Bob. Pigtail catheter. It's okay. Pigtail catheter.
Yeah.
It's okay. Don't worry about it. So yeah, these sheaths leak a lot around these wires. Very good. Okay. Now we're going to do the same thing we did on the other side. I'm not sure we're going to need to extend, to be honest with you. You can see that we're pretty close already. I'm going to do that same 20/20.
Yeah, the common iliacs aren't that long in this case. They average
No,
at least
they're not.
5 centimeters, but in this case, the left is shorter for sure.
Beautiful. So I'm going to go ahead and inject here, Bob, and let's go non-subtracted, no subtraction.
Yeah.
Got a little flush there.
Yeah, mostly saline.
Nope. There it is. So, I mean, it's maybe 1.5 centimeters.
Right, at the
Do
most.
we need to do anything with that? I don't think so.
No,
Do you
in
guys
the other
wanna do
room,
anything
in the other room, we left it like that too. It looks like you have about 3 centimeters of coverage in the common iliac already, so you probably don't need to.
I think we do, yeah. Let's take the balloon. Okay, we're going to take the balloon and finish up with the balloon. Go ahead. You know, I think it's been said before at other meetings, but in Asia, it's more common to have a fairly short common iliac as compared to Caucasian U.S. patients, for sure.
Right, anatomy overall, the entire length tends to be shorter.
Right, but especially
well,
the common
especially
iliac.
common iliac
bifurcation-
length.
Yeah. So I try not to push that issue too much. I think we have plenty of coverage here.
I would agree.
Yeah. All right, let's go up here and hit the top.
So this is a Reliant balloon?
It is, yep.
So again, just
Maybe
pressing
we'll push that
fabric
up a
and
little
molding
higher.
it. Might want to go just a little higher.
Push that up a little. Yep, exactly. There we go. Actually, you can go ahead. It's got a little bit of an angle there, so that's what we missed.
So he's going cranial to
Taking that
eliminate the
parallax out.
parallax.
That's much better.
That's good.
Yep, that's good. Okay, you can store that fluoro. Let's pull that back. We're going to do just the distal mark. Keep coming. Right there. So I'm going to get this iliac real quick. And, because it's a compliant elastomeric balloon, I don't take it right to the edge of the marks because I think it does tend to bleed over, and you can then have an inadvertent dissection. Go ahead.
Well, that's very true. Yeah, he's staying inside
Hold on.
the graft edges. And all he needs is a light tap. It doesn't have to be that strong.
There you go.
That's good.
Okay. Yep. We'll go on the other side.
Okay, now he'll do the other side with the overlap junction out into the internal iliac.
It's okay. Okay, whichever. It's good. We'll take this one off.
So while he's
So we're
working
just going to
here,
manage our bleeding here.
while he's ballooning, let's pull the panel on follow-up surveillance. Who still is doing CT angiography and who's doing ultrasound-guided surveillance of these endographs? Comments from the panel?
When the kidney is normal, I try to stay with the CT scan, but creatinine has little problems. Recently I do the ultrasound with the ultrasound contrast.
So many of us have evolved to, say, doing the 30-day with contrast to make sure there's no endo leak, and then if it's a well-functioning graft with no endo leak, then transition over to ultrasound. Is that, I'm hearing some nods in agreement, a lot of operators doing that?
Yeah, I would agree with that.
We need to overlap your
Mm-hmm. Wire? Okay.
This is an important step here because even though he has a good degree of overlap, if you don't eliminate the pleats and folds, you can see an endo leak, which, you're not certain if it's type 1, 2, or 3. And you just see contrast filling relatively early, lower in the sac, and it's often because there's a gap in the overlap junction. So it's always helpful to balloon that before you take a final image.
So Bob, we're going to take a final image, as you said, and then we'll start our per close. Dr. Kang and Choi have already done that very well, so I'm sure it's going to be great.
Yeah, so it's been pre-closed.
Okay, wire out. Okay, big injection.
Maybe
Can we
set it
hold
up,
breath?
pan down a little so we can
우리가
see the outflow
말씀드리면
too.
지금 아니고요. 이제
Yeah,
말씀드리면
we're going to do everything here.
There we go. That's good.
Okay. And yes, please.
DSL을 주시고요. 준비됐나요?
Okay, everybody ready?
네. 그래서
Inject.
됐습니다.
So importantly here, it looks like a good seal up top. You can see daylight between the limbs. That's always a good sign that you don't have a type 1 leak. And then very late, you're seeing some, looks like egress through a patent lumbar distally. But I don't think it's coming from above. Might be transgraft porosity or something. See that? But it looks very good.
Yeah, I don't see it yet. I think it looks pretty good too, and it doesn't look like a type 3 either.
No, I think that's very acceptable. Panelists, what do you think? Or is he done?
Textbook.
Textbook. We're hearing textbook. All right.
All right, that's
You're to
great,
be
guys. We appreciate
congratulated.
it.
Very nice demonstration and on time. You're to be congratulated, the whole team there.
Bob, thanks to everybody there, Dr. Cho, Dr. Kang, everybody, Medtronic rep helping us put everything together here. And we'll see you back at the convention.
Very nice job. We'll go back to the other room just to see their final. Okay, back to the other rower. Drs. Lee,
Hi.
show us how
Yeah.
you finished.
Yeah, we balloon in the left side around the common iliac artery. So this is Swiss angiography to see the type 1B. So you can see I don't know exactly the problem. What do you think about?
I think it's okay. Huh? This is very minimal.
Dr. Lee, I think it's very nice.
I think it's fine.
I think there is some calcification in the left common iliac artery, and that caused the, some insufficient position. And now at this moment, but with time, I think the endoleak will go away.
Yes. Usually if you inject forcefully retrograde like that and you see that little, that should resolve just with reversal of anticoagulation. I don't think this will be an issue. I think it's acceptable. It looks good. Very well done.
Okay, we want to close. Thank you.
Thank you very much. So that concludes our session of life cases for endovascular AAA. Thank you very much for attending. Appreciate everyone's attendance. Thank you.